The next slide deals with reimbursement, and of course one explanation of increasing reimbursement might be increasing costs. One measure of increasing costs in the industry is the Skilled Nursing Facility Market Basket Index that I guess Medicare puts together, and that's the dashed line that you see on slide number 6. And this slide compares the Arkansas nursing, the average NF reimbursement rate to Medicare's SNF market index, and shows the cumulative impact. What that also shows is the correction. You can see now obviously where that correction in Arkansas Medicaid reimbursement rates really happened in the early part of the last decade. Since that time, take 2002 or 2003 as a starting point. We don't do that. We use 1999, but if we had, we would still see separation between the cumulative increase in rates in Arkansas and the cumulative increase in costs as measured by the SNF Market Basket Index. Now, this is an observation. We're not drawing any specific conclusions from this. We wouldn't use necessarily this ratio or these numbers to drive changes in payment policy. It's just an observation. The next slide takes, again, looking at average reimbursement rates and comparing growth in reimbursement on slide 7 to our neighboring states. Again, starting with the time frame 1999, and you see that the changes made early in this period had the intended effect of increasing Arkansas Medicaid's reimbursement rate. It started off at the lowest of these comparison states. By the way, we're still adding Mississippi and Louisiana, and certainly we'll want to, if we're able to get that, share the more complete comparison with you. But compared to Tennessee, Missouri, Oklahoma, and Texas, we did start off at the lowest level in 1999. Our data here from Health Affairs shows, is that right? Where are we getting to 2010? I guess that's from the association. So we're now at the highest level across states. And by the way, if there are ways to improve these, these comparisons or adjust, etc. I know, some states, a lot of states, I think most have an assessment, for example, a bed fee or a tax, if you will, and that's obviously going to affect the reimbursement rate because that tax is normally treated as a cost, so it's a pass-through. And if there are suggestions, in the Q&A, we could take those kind of suggestions, or afterwards, if you want to suggest to us ways to improve these comparisons. Certainly want to do that. One of the unique aspects of reimbursement to nursing facilities, there are a couple of other provider types like this in the Medicaid program in the healthcare world, where Medicaid is a pretty big percentage of the business, where it's an institution where you have both fixed and variable costs, and just pointing out that if Medicaid, let's say in a physician's office, is just 10% of the client base, then we may not expect Medicaid to deal with the fixed costs, the investment costs, the bricks and mortar, etc., the data systems. It may not be, hopefully we are paying our freight, but if we're not, it's not as big a deal as in nursing facilities where we're a big percentage of the business. If we're not paying, Medicaid isn't paying its share of those fixed costs, then there's a real question whether the facility is sustainable or not. As a result, Medicaid, because it has some responsibility to look at the viability of the nursing home and incorporating the impact of fixed cost on the business model, then it means Medicaid does have to pay attention to the other payers, or if there are fixed costs that are essentially, if there's capacity within a nursing home that's idle, that's capacity that is not paying its share. So we're looking at facility occupancy here, and at least with this data, looks to be below the national average. So the national average, what is the national average? Is that listed here, folks?
83%.
I am not a very quick reader. Oh, over there at the right, 83%. Arkansas is about 10 percentage points lower than that. The more detailed data on the left shows by numbers of nursing homes how many fall into each category of occupancy. So overall, about 4 out of 10 nursing facilities have an average occupancy below 70% over the course of a year. We do want to pay attention to the fact that demographics or geography does matter. Proximity to the client matters, and we don't have Little Rocks in every county of the state, so we did look at some rural states as comparison. I don't want to argue that this is highly scientific, and again, the point of this meeting today is mainly to level set on some of the data, basic data, but other rural states, South Dakota, Kentucky, Mississippi, had much higher rates of occupancy. Say a little about the way that nursing homes are paid. I'm going to do my best here to relay the methodology. This is on slide 9. And you see on the left there the distribution of nursing home payment by the portion, by the 4 components of the formula: direct care, administrative costs, capital investment, that's the fixed investment I was referring to earlier, and other, which a large part of which would be provider tax. Direct care makes up 60%. I believe this was the focus of the payment reforms early last decade to incentivize. In fact, there were changes in either law or regulation encouraging higher nursing staff ratios. That was explicitly incentivized, and that has an impact on how we pay. So direct care, there are allowable costs to labor and supplies, durable medical equipment, the things that you would see more of if you have more residents and less of if you have fewer residents, the variable cost. And they're divided equally among clients, and that's what yields the facility-specific rate. Just a simple math. So a ceiling is established annually, and so that ceiling is set at 5% higher than the average costs of the 90th percentile facility for direct costs. So if you're at the 95th percentile, the 100th percentile, you're not getting any more than the 90th percentile. I'm sorry, if you're more than 5% higher than that 90th percentile, then that's the ceiling. Labor, as with almost any business, majority of the cost, certainly for this portion, which is the variable cost, is 75% of that direct care portion. A couple of other details. The facility class-based per diem, I can't even describe what the facility class is divided amongst clients to determine a per client. This to me just reads like it's an average. You can help me out if I'm missing something important there. Class rates must be rebalanced at least every 3 years at 110% of the median for each class. If there are questions on that, I'm going to have to ask someone else to answer them. Jim?
I would just like to point out on the capital component, and it will relate back to your previous slide on occupancy rates, there is a penalty for low occupancy any facilities below 80% start getting penalized. So that way, the inefficiencies that are shown on the previous slide are not necessarily costing the state any more money. And it also would tell me that we're doing a pretty good job on home and community-based services compared to some of those other states.
Fair points, and it raises the following question. As we look ahead to,
it's just a real quick follow-up on that, and then we can move on from that part. That South Dakota, Kentucky, and Mississippi, their home and community-based rate is only 15% when we're at 40. So that makes Kentucky's is an 87-13 split. I mean, South Dakota's is. So I mean, if we only had 13% home and community-based services, we'd have closer to a 90% rate too.
That's a fair point. We ought to find some states that maybe match us a little better in the balance of home and community-based and nursing facility costs that are also rural. It also raises the question, as we look ahead to the payment reforms, which of these components of the payment methodology we're mainly focusing on. I think you can hear the foreshadowing in all of my comments. We clearly want to focus on the direct care component. It is an open question how much we need to focus on the admin, the capital, and the other. I think it would be unlikely that we could leave them alone, because if we reform the direct care, that may have a significant impact on what any individual facility gets. It was designed as a package to begin with, so we may have a hard time, if our target is the direct care portion, we may have a hard time just looking at changes to the direct care portion, because that may upset the apple cart. All of that is to say that we haven't made a decision that we are satisfied or dissatisfied with these other components, the admin, the capital, and other.
Could you give a more specific explanation of what you're talking about on reform of direct care?
So any reform of direct care would be designed to address the challenges we've just identified. So the lack of correspondence between quality and outcomes. That's a core goal of payment improvement, is to pay for outcomes, to pay for quality, and we don't do that. We don't do that essentially almost anywhere in Medicaid, so it's not targeting long-term service and supports. We don't do that for community-based services either. We're going to get to that in a second.
So if we can make a determination of what that quality is, that definition, and these other factors in it, it could actually mean an increase in direct care?
It's unlikely that we're talking about an overall increase in direct care given the comparisons and the increases that we've talked about.
And I made a comment.
However, what does it mean to pay for quality? It means you pay more for higher quality than you do for lower quality. What we've also talked about is, are we going to have a competition like the 5-star rating every year? Or are we going to encourage everybody, and a principle of payment improvement in other areas that we don't plan to break in long-term service and support is everybody should be able to win. If we're going to reward quality, then everyone ought to have the chance to reward quality. So in the dimension of quality and outcomes, we want to leave open and create the incentive and the possibility, the realistic possibility, that everybody could win. I want to be honest with you. It doesn't appear that the overall rates are too low. We're proportionally higher. The other direction that we're looking at is to vary the rate that we pay for individuals according to their level of need. In which case we would end up paying more for the higher needs patients and potentially less for the lower needs patients. So I just want to be as transparent as I can. For those who I talk to you individually, I always say that. I've said that since I arrived, and I want to answer your question as honestly as I can. But as we started off today, indicating today is talking about data, What are we missing? What do we need to measure? Because that's going to be the starting point for these reforms and will help answer just how much and what our goals are in reforming payment.
Well, and